Hello, everyone. So what happens when a patient presents with aortic valve disease, but also dilated left atrium and right atrium in the setting of persistent atrial fibrillation and atrial functional tricuspid regurgitation? In this episode, we're going to show how to do a RAVR in conjunction with a tricuspid valve annuloplasty, suture-based, such as the VIII procedure, as well as a biatrial Cox-Maze. Let's have a look. So now we have a patient who presents with severe aortic valve disease, severe atrial functional tricuspid insufficiency, and long-standing persistent atrial fibrillation, who was robust but 80 years old. Now, transcatheter options are possible, but would require a tricuspid intervention, aortic valve intervention, ablation of the atrial fibrillation, as well as left atrial appendage occlusion. Here we approach this all in one procedure performed robotically, starting with the biatrial Cox-Maze, as we've demonstrated before: epicardial coronary sinus lesion, endocardial left atrial ablation of the inferior box into the appendage, the superior box lesion, then the mitral line, and then performing the vertical atriotomy in the caudal third of the atrium. And this clearly will expose the tricuspid valve, which you will see later: tricuspid completion line lesion, SVC lesion, right atrial appendage lesion, and inferior vena cava lesion. And here we have the tricuspid. So the tricuspid annulus was 5.1 centimeters. And in this elderly patient with atrial functional tricuspid insufficiency that was significant, we elected to perform a suture annuloplasty. We've demonstrated previously that ring annuloplasty with a prosthesis is definitely feasible. One of the challenges sometimes with a large annulus and a rigid prosthesis concomitant to an aortic prosthesis is the potential risk of a pacemaker. We wanted to be careful about that, plus of the patient's age and functional status. And here is the completion of a 2-layer deep bite suture annuloplasty, or de Vega technique, which in selected cases, such as this one, it provides an excellent solution. We can size this carefully to the annulus, creating two-handed tension to get good coaptation, and then with my other two hands can tie this down intracorporally. And here's your completed tricuspid annuloplasty. We then close the right atrium, the first bite being a running suture, as we have demonstrated previously. The second bite, or second stitch coming up, is a Lambert light suture to have an excellent 2-layer closure. Now, once this is complete, we then turn our attention back to the left atrial appendage, which we've demonstrated previously, which is a 2-layer obliteration. First layer incorporating the body of the left atrial appendage in an accordion-like style. The second layer is then, again, a Lambert-like suture to bring the plication of the left atrium in a homogeneous and longitudinal fashion. And this is important because this patient obviously wanted to avoid the challenges of anticoagulation. So this sort of one-stop shop type of solution would be part of our strategy to avoid oral anticoagulation postoperatively, which this patient was managed this way. And here completes the left atriotomy closure in our previously demonstrated vertical mattress style in 2 layers, but with 1 suture. Once the atriotomy is closed, then our attention is directed back to the aorta after antegrade cardioplegia is delivered. We now make our aortotomy. And here in this 80-year-old patient, the aorta was pretty devoid of calcium, although sclerotic. And here are the leaflets now being excised in a very meticulous way. Again, to debride any and all calcium. Flush with the annulus. In this case, starting with the right coronary leaflet, followed by the non-leaflet. This is usually our routine, followed by the left coronary leaflet. You can see just getting into that plane initially becomes very important to get the most optimal single plane resection of the leaflets, going back to sometimes when that's not possible, debride the last few elements. Again, using suction aspiration, and then following this significant irrigation, and then placement of the sutures as we've demonstrated previously, starting at the non-left commissure and performing this circumferentially, keeping the camera coaxial in the midline. And I'll just make a comment, because obviously this can be done transcatheter, but for a patient like this that can treat the patient's atrial fibrillation, tricuspid insufficiency, and provide a anticoagulation-free solution in this smaller patient, we elected to put a 21 millimeter valve in, which fit nicely. Her total BMI was only 21. And here is the prosthesis being delivered after extracorporeal suture placement with the left-right commissure first, followed by angulation to fit nicely into the non, starting suture securement with suture fasteners, and then completion of the aortotomy. Once again, demonstrating the two-layer closure. First layer is a horizontal mattress, second layer is a running suture. And this, as I had mentioned before, is approximately 18 to 20 minutes, though this could be shortened if the team wishes to use a single layer. We find this is optimal. Pacemaker wires are placed. The patient was then reanimated, weaned from cardiopulmonary bypass, and here's the final result with no residual tricuspid insufficiency or gradient, with an intact aortic valve with a mean gradient of only 9 millimeters of mercury. Patient was extubated in the operating room and was discharged in normal sinus rhythm without the need of a pacemaker on aspirin only and oral amiodarone prophylaxis for 3 months, and has done very well. So now we've seen how to do a RAVR with tricuspid valve annuloplasty in a maze. Let's have a look in our next episode when we now have a patient that presents with concomitant mitral valve disease.